Good morning, good afternoon, good evening, wherever you are. Dear colleagues, dear friends, it's my pleasure to present acute respiratory failure in patients with hematological malignancies. I am Dr. Elie Azoulay from the St. Louis Hospital in Paris. These are my disclosures. Well, we are dealing with a disease that affects a third of ICU patients. The first reason for ICU admission is acute respiratory failure in every kind of immunosuppression. Mortality in these patients varies between 35 to 70%. The definition of acute respiratory failure hasn't been challenged since a while. We are having signs of respiratory distress. We are having a new pulmonary infiltrate, as well as hypoxemia, as defined by a low PF ratio, PaO2 over FiO2. The incidence of acute respiratory failure varies a lot according to the type of malignancy. In patients with prolonged neutropenia, patients with acute leukemia, or patients who are BMT recipients, we can have up to 40 to 50% of respiratory events and pneumonia. In patients with lymphoproliferative disorders, lymphoma, acute lymphoblastic leukemia, we are having more 20% of patients developing acute respiratory failure. It's much lower in recipients of solid organ transplants, 5% overall, 10% if the organ transplanted is the lung, and it's the same for oncology. It's very low in oncology, but around 1 to 2%, and can reach 5% in patients with lung cancer. Overall, in Europe, it's more than 500,000 patients every year admitted to the ICU for acute respiratory failure. To manage the patients, there are 3 steps. The first one is to use the GPS, so to try to understand, based on the clinical findings, what is the most probable cause of acute respiratory failure. Then you need to define what are going to be the diagnostic tests, and then you are going to properly make the diagnosis using a non-invasive or an invasive diagnostic strategy. These are 6 patients that we had in the ICU recently. And as you can see, you have a patient with the comorbid conditions. You have the underlying, you have the underlying disease, myeloma, chronic lymphocytic leukemia, acute lymphoblastic leukemia, lymphoma, T-cell lymphoma, B-cell lymphoma, and you have the clinical presentation like a shock, or the fact that we are not in an acute, but maybe a subacute respiratory failure in 4 days, whether there's a hypotension, flu-like syndromes, signs for sepsis, or any other organ dysfunction. And based on all these elements, the disease, the clinical situation, and the clinical signs, we are going to establish the probability for a pre-test diagnostic strategy. So then, the best to do is to analyze every single situation according to the DIRECT approach, the direct approach. D is the time since the patient has the malignancy. I is the pattern of immune deficiency. R and T are the radiology. E is the clinical experience. And C is the clinical picture. Overall, when you look at the literature, you can see that most patients coming to the ICU for acute respiratory failure are having mostly bacterial pneumonia, then pneumocystis pneumonia, viral pneumonia, disease related to infiltrates related to underlying disease, invasive aspergillosis, cardiac edema, and other cause. However, for about 15% of the patients, the etiology of acute respiratory failure is not established, and then the patient has to undergo more diagnostic or sometimes therapeutic strategy to overcome the lack of proper diagnosis. Let's look at the direct. So the direct in a patient with hematological malignancy can be either the patient is very sick at the earliest phase. In blue, you have patients with lymphoproliferative disorder. In red, patients with myeloproliferative disorder. And you can see that according to the clinical situation, if they are coming very early, in red, we are more into underlying infiltration. In blue, it's more about infection. The same is if it happens at the early phase. But then when we go into the deep neutropenia and after neutropenia recovery, we might have different diagnosis. And in patients with lymphoproliferative disorder, of course, when there is a T-cell defect, we are entering into a risk for opportunistic infection. So for every patient, we need to consider whether neutrophils, macrophages, B cells, T cells, and antibodies are in the normal ranges quantitatively and qualitatively. And if there is a defect in these cells, it can be either related to the disease or to the treatments that the patient receives to get cured of the disease. So then, according to the cell that is mostly in defect, you will be able to define those risks for specific infections. The radiology is also very, very important. Of course, not every patient can have a CT, but even on the chest X-ray, you can assess whether the patient has interstitial disease with the corresponding ground glass opacities or micronodules on the CT. You can define whether there are macronodules, whether there is consolidation, cavitation, whether there is a pure alveolar syndrome, or whether there is a pleural infusion. As you can see on this slide, you can not only assess what are the probability for a specific diagnosis, but also the way you are going to organize the patient management to get the appropriate diagnosis. This is, for example, a patient who has never been treated and coming to the emergency department for acute respiratory failure, pulmonary infiltrates, and hypoxemia. And this looks like a patient with an HIV disease, but he is not HIV positive. The patient is HIV negative. But on the blood test, you can see that the patient has a T-cell leukemia with 34,000 cells. And we know that for those patients, at the earliest phase of T-cell leukemia, it's very likely to be a pneumocystis. You can see here that when we look at pneumocystis in patients with T-cell leukemia, 3% of the patient had never received any treatment, and we would require to have a proper diagnostic assessment to rule out pneumocystis pneumonia. So you can see that the D and the I of the direct attitude will help you. For example, if you're at D0 for a patient with hairy cell leukemia, and we know that hairy cell leukemia, the I is that there is a specific defect in macrophages and monocytes. So the patient is at a higher risk for intracellular bug. And this patient is not going to undergo bronchoscopy, but just a urine antigen test to diagnose Legionella. We know that if the patient is not at D0 but day 15 and had received a treatment for the hairy cell leukemia, it's very likely to be drug-related pulmonary toxicity, and the patient has to undergo bronchoscopy because it's going to be full of eosinophils, and the patients will be cured using steroids. Another example now, it's in acute myeloid leukemia, and we know that those patients are having pulmonary infiltrates very early in the diagnosis that we call leukemic infiltrates. If it's with a huge number of blast cells, this is leukostasis. If it's a small number of blast cells, we are more into leukemic infiltrates. But if the patient had received chemotherapy for the leukemia and then develop pneumopathy, so then the patients will have a lysis pneumopathy. Looking at this, we need to understand that there is always a translation between the diagnostic concept and what we have in the lungs. You can see here that this is leukostasis with a huge number of blast cells filling the pulmonary artery, and we are going to have a very little specific pulmonary infiltrate, and maybe here a superinfection with consolidation in this left posterior inferior lobe. But here you are not having the same disease. You are having an infiltration of the septal lines, showing very clearly that there is a pulmonary infiltration. So the first patients need to undergo what we call a very slow decrease in the number of blast cells. And this is very important because if we are giving chemotherapy, we are going to produce lysis pneumopathy. However, in the other case, the patient just needs to be neutropenic and will have a classic chemotherapy and will be cured of respiratory infiltrates just when he will or she will become neutropenic. This concept has also to be included in the more global picture of a patient with here leukostasis with blast cells coming up in all the mucosa, all in here the skin and other organs. So this was the first clinical presentation of patients with leukemic infiltrates with acute monoblastic leukemia, and very clearly you can see that the septal lines are involved by the leukemic cells, making that we have a pure pulmonary infiltration that will be cured very quickly when the patient will be neutropenic with no circulating blast cells. However, if the patient has a huge number of blast cells, we will have more a leukostasis, and we need to have really a slow decrease in the number of blast cells as to be able to avoid lysis pneumopathy in those patients. The problem to make a diagnosis is that the classic use of bronchoscopy and bronchoalveolar lavage, BAL, is not always possible in these patients, either because they bleed or sometimes, and this is also very important, because they are very, very hypoxemic, and the risk is that we will then escalate to intubation and mechanical ventilation after bronchoscopy. This was suggested by this paper published 10 years ago by a French team, showing that being immunocompromised was a risk factor for getting intubated after bronchoscopy, and other studies have reported that more recently. In a trial that we performed 10 years ago, we demonstrated that having or not having bronchoscopy and BAL was really not a problem to identify the acute respiratory failure etiology, and it was not associated with an increase or a decrease of escalation to mechanical ventilation. As you can see here, in the two groups, the proportion of patients requiring intubation, not or having a diagnosis or surviving, was exactly the same in the two randomized groups. We still do BL, and we would do, I would say, in about 1 in 5 patients. These are two typical cases, but there are many where BL is really mandatory. I would say that it's very complicated for us not to have BL when the patient has an interstitial disease, ground glass opacities, nodules, etc. But sometimes you cannot go to BL and you have to use non-invasive diagnostic tests that we are going to see in a few slides. That being said, we need to understand that in these patients, BL was not only the appropriate test to perform the diagnosis, but it was also life-saving in these patients who were cured from their underlying disease and acute respiratory failure after the diagnosis could be identified. 2 years ago, Professor Bauer and all our group that is called the 9I, so we are a group of 16 countries all over Europe, and we are having more and more centers joining us on a regular basis. And our group has performed a study that was called EPHRAIM. And in this study, we compare patients having or not having bronchoscopy and BAL. And interestingly, the patient having bronchoscopy and BAL were having a higher mortality, 40 versus 28%, than patients not having BAL, and despite the propensity score matching, showing very clearly that this patient, we need to make the appropriate diagnosis strategy, but also using the appropriate diagnostic tests. So what are the non-invasive tests? Of course, it cannot be fever, it cannot be leukocytosis, it cannot be biomarkers. We never use biomarkers. And we were very upset from every PCR and rapid detection tests. So we need to diagnose disease and not colonization. We need true CMV invasion. We don't need positive CMV PCR. The same for VRS, the same for herpes, for aspergillus, etc., etc. So the question is, we want to avoid one thing. We want to avoid the lack of etiology and not knowing what is going to be the appropriate diagnosis. That being said, we need also to highlight that in these patients, it's not the fact that we do or don't do a bronchoscopy that makes the diagnosis. We need to be able to identify the diagnosis. In this study by Dr. Contejean and colleagues, we were able to demonstrate that adjusted on every confounder, including, for example, SOFA score, aspergillosis, and mechanical ventilation, undetermined diagnosis in patients with acute respiratory failure was associated with mortality. So why? Why there is an increased mortality in these patients? Sometimes because we can't identify or suspect and treat a condition. Sometimes is that we treat it, but not really optimally. Sometimes we treat only one of the two pathogens. Sometimes we treat the infection or the non-infectious cause, but not the two. And sometimes we consider something relevant that is not relevant, and actually we miss the diagnosis. This is a very important study performed by Professor Van der Loo in the United States, and they went to see what were the results of autopsy study, data in 107 AML and HL patients dying after acute respiratory failure. And in more than half the cases, a major diagnosis was missed. And as you can see here, most of the diagnoses that were missed were either fungal infection or underlying infiltration by the disease. This is why we have started a randomized control trial where patients with no diagnosis between day 3 and day 5 are randomized to receive a combo of antifungals and or steroids. Now, if we want to get more into important data, we need to be able to develop the omics strategy in these patients and to be able to identify the bugs that are involved in the patients, either by PCRs, much more by NGS or metagenome, or sometimes by using transcriptomic data or going even beyond that. Just to give you an example, this is a very important paper that provides an algorithm that is developed using machine learning that offers an integrated genomic portrait of pathogen. Then it adapts this portrait on the airway microbiome and the host transcriptome. Based on the different steps in this study, you can then identify what is going to be the profile of the patient with a specific diagnosis, take the picture and apply it in patients with no diagnosis. The most important thing is to rule out diagnosis for those conditions that request either very toxic or sometimes very harmful treatments or sometimes very expensive treatments. So the work that we are now performing is to try to understand how the transcriptomic data can help us identify the cause of acute respiratory failure in patients with no diagnosis. Pediatricians have used that for viral infection, and I must say that we are now using much more PCR than NGS. And this is a study published 3 years ago by our group, where patients all underwent a PCR from the respiratory samples. And as you can see, a PCR not so often identify a bug, but when it's positive to any virus that is mimicking flu, like influenza, of course, but also parainfluenza virus or RSV, we know that when we are going to have this, it's going to be associated with either the need for mechanical ventilation or death. And this is very important because it might be a way to stratify very harmful treatments or sometimes very expensive treatments. So the work that we are now performing is to try to understand how the transcriptomic data can help us identify the cause of acute respiratory failure in patients with no diagnosis. Pediatricians have used that for viral infection, and I must say that we are now using much more PCR than NGS. And this is a study published 3 years ago by our group, where patients all underwent a PCR from the respiratory samples. And as you can see, a PCR not so often identify a bug, but when it's positive to any virus that is mimicking flu, like influenza, of course, but also parainfluenza virus or RSV, we know that when we are going to have this, it's going to be associated with either the need for mechanical ventilation or death. And this is very important because it might be a way to stratify the patients to be admitted to the ICU or to any other ward. This is another example of a clinical score that we developed to diagnose pneumocystis in these patients. And we have clinical variables that are associated with the diagnosis of pneumocystis. However, we know that we need to, even if this score is very relevant and performant, we need to add to this score other elements, like, for example, biomarkers. Beta-D-glucan is very relevant for the diagnosis of pneumocystis pneumonia, but also transcriptomic data that will help to identify the probability of the diagnosis based on the response of the host. So we are more working on fine-tuning the clinical algorithms by biological markers coming either from very validated biomarkers or from the omics strategy. This is another example in pneumocystis pneumonia, where you can see you have yellow, red, and blue for 3 different clusters of gene expression. And based on that, we would see whether patients have the yellow, the red, or the blue, trying to understand if the risk of pneumocystis based on transcriptomic data is still very relevant. Thank you very much for your attention. I was very happy to have you listening to this lecture. And I welcome you in Paris in January 23 and in March 23 for the training course on blood disease in the ICU or for our research meeting in March. Thank you very much and have a very good day and very good conference.